tumor, bone tumor. Bone tumors can induce osteomalacia. Osteomalacia inducing bone tumors are fibrosarcoma, osteoblastoma, osteosarcoma, non-ossifying fibroma, hemangiopericytoma হচ্ছে তোমার fibrosarcoma, osteoblastoma, osteosarcoma, non-ossifying fibroma, hemangiopericytoma. Fibrosarcoma, osteosarcoma, hemangiopericytoma, non-ossifying fibroma, osteoblastoma. These are osteomalacia inducing tumors. Now, by dividing the tumor into these groups, epiphyseal, diaphyseal and metaphyseal. Epiphyseal tumors are the osteoclastoma, that is the giant cell tumor, and chondroblastoma, that is the tumor which is formed before skeletal maturity, that is in child before skeletal maturity, and in X-ray we see stippled calcification and stippled calcification. This is chondroblastoma. And the giant cell tumor occurs after maturity. There is no epiphyseal plate here. There is epiphyseal plate here. After skeletal maturity, osteosarcoma is formed. What is osteoblastoma is formed? Osteoblastoma is before skeletal maturity. Osteoclastoma is after skeletal maturity. Giant cell tumor. It is the most common bone tumor at 20 to 40 years. X-ray shows soap bubble appearance. Clinical features is eggshell cracking. Soap bubble appearance and clinical features is eggshell crackling. Can grow up to 1 to 1.5 centimeter up to the joint or cartilage. Biopsy shows rank positive multinucleated osteoclast-like cells surrounded by mononuclear cells. This is osteoclastoma. Osteoclastoma means we will have multinucleated osteoclast-like cells surrounded by mononuclear cells, and these are all rank positive because they are osteoclasts. Less than 5% are undergo malignant transformation. Metastasis goes to the lung mets, and in the this rank positive multinucleated osteoclast cells surrounding the mononuclear cells are the proliferative part. What is the management? Treatment is extensive curettage with autograft, liquid nitrogen, bone cement and phenol is given. So epiphyseal tumors are two, osteoclastoma and chondroblastoma. Osteoclastoma is the giant cell tumor occurring after skeletal maturity, most common tumor at 20 to 40 years. Clinically, it shows eggshell cracking. In X-ray, there is soap bubble appearance in the epiphysis, and it can grow into the joint and the cartilage 1 to 1.5 centimeter, Biopsy shows rank positive or giant osteoclast cells surrounded by mononuclear cells. Mononuclear cells are the proliferative part, and less than 5% malignant transformation occurs to lung metastasis. And treatment is extensive curettage with autograft. Extensive curettage is done by liquid nitrogen, phenol, and then bone cement or autograft is given. After this, we come to the diaphyseal tumor. These are the diaphyseal tumor: fibrous dysplasia, Ewing sarcoma, osteoid osteoma, adamantinoma. These are the diaphyseal tumor. So, coming to Ewing sarcoma. Ewing sarcoma. This is a malignant tumor. And adamantinoma is also a malignant tumor, mostly in the tibia. Ewing sarcoma is a high-grade malignant tumor. It is a high-grade malignant tumor, and X-ray shows onion peel and Codman's triangle. IHC is MYC2 CD99 positive. Biopsy shows small round blue cell tumor, pass positive, diastasis, digestive. Gene translocation is 1122 mesodermal to ectodermal. Radiosensitive tumor. So treatment is limb salvage by resection with radiotherapy. In the clinical features, if there is inflammatory signs of inflammation, then it indicates poor prognosis, and there is a swelling in the middle of the bone, because this is a diaphyseal tumor. So diaphyseal malignant tumor is Ewing sarcoma, which has a onion skin appearance in X-ray and Codman's triangle lifting up the periosteum because of its high-grade malignancy. This is most commonly seen in second decade, that is 20 to 30 years, and IHC is MYC2 CD99 positive. Biopsy is small round blue cell tumor, pass positive, diastasis, digestive. Gene translocation of 1122 and from mesodermal to ectodermal. It is a radiosensitive tumor, that is why in the treatment we use chemotherapy, then limb salvage and resection, and then radiotherapy. If inflammatory signs are present, this is poor prognosis, and the patient presents with swelling in the middle of the bone. This is Ewing sarcoma. Another malignant tumor is the adamantinoma. Adamantinoma shows a soap bubble appearance in the X-ray. It is formed from the aberrant epithelial cells that grows into the subcutaneous bone, that is tibia. Aberrant epithelial cells that grows into the subcutaneous bone. Here the tumor became mesodermal to ectodermal. Here the epithelial cells are going into the subcutaneous bone of tibia, forming a soap bubble appearance, and this is malignant in nature. Osteoid osteoma and fibrous dysplasia are the benign forms of diaphyseal tumor. Osteoid osteoma is a tumor most commonly less than 2 centimeter nidus, produced by 2 centimeter nidus of dilated blood vessels. These dilated blood vessels produce prostaglandin. Because of this prostaglandin, there is a sclerotic rim of osteoblastoma and woven bone of osteoclasts. So there is a sclerotic rim, there is a woven bone, and the inside there is dilated blood vessels which release prostaglandin. So in the treatment we use NSAIDs and radio frequency ablation. If the diameter of the osteoblastoma is more than 2 centimeter and most commonly it occurring in spine, then it is said to have shown malignant transformation and it is known as osteoblastoma. Osteoblastoma. Fibrous dysplasia is a tumor which is seen in metaphysis as well as diaphysis. Diaphysis more than metaphysis. It is associated with Mazabord and McCune-Albright syndrome. Mazabord syndrome and McCune-Albright syndrome. Mazabord syndrome is associated with myxomas. This is a developmental anomaly and that is why associated with the genetic syndromes McCune-Albright and Mazabord. Mazabord is associated with myxoma. Bone tissue is replaced by woven bone and fibrous tissue. Bone tissue is replaced by woven bone and fibrous tissue. That is why it is known as fibrous dysplasia. And it can be monoosteotic or it can be polyosteotic. If it is monoosteotic, it occurs in the femur most commonly, and if it is polyosteotic, it can occur in the maxilla more than femur. In the femur, it forms the shepherd's crook deformity, in which there is ground glass opacity or lucency in the neck of femur, and there is a rind sign of the sclerotic rim. In biopsy, it shows Chinese letter like appearance. So fibrous dysplasia is a benign tumor. It mostly occurs in the diaphysis than metaphysis. It is associated with genetic deformities, genetic syndromes, Mazabord syndrome and McCune-Albright syndrome. Mazabord syndrome is associated with myxoma, and McCune-Albright syndrome is associated with the cafe spot, precocious puberty and fibrous dysplasia. The bone tissue is replaced by woven bone and fibrous tissue, and most commonly it occurs in the femur, which makes the shepherd's crook deformity with the sclerotic rim known as the rind sign and the ground glass lucency of the neck of the femur. And in the polyostotic type, maxilla is more affected than femur. In biopsy, it shows Chinese letter appearance. So we have finished fibrous dysplasia, Ewing sarcoma, osteoid osteoma and adamantinum. So now we are going to study the metaphyseal tumors. What are the metaphyseal tumors? The metaphyseal tumors are osteosarcoma, chondrosarcoma, osteochondroma, non-ossifying fibroma, aneurysmal bone cyst and unicameral bone cyst and enchondroma. Okay, so osteoid sarcoma, osteochondroma, chondrosarcoma, unicameral bone cyst, aneurysmal bone cyst, enchondroma, non-ossifying fibroma. So coming to osteosarcoma. Osteosarcoma is a malignant metaphyseal tumor which gets converted from osteoblastoma. Osteosarcoma is radio-resistant, unlike Ewing sarcoma. It is radio-resistant and it is radio-induced. It is pulsatile immature bone. Pulsatile immature bone cannot go to epiphysis by spreading through the periosteum, Because it occurs in the immature bone, it cannot go to the epiphysis. So it occurs in the metaphysis only, and it is pulsatile in nature. And it occurs, it is two types, primary and secondary. In primary, it occurs at the age of 10 to 20 years, and it is most common in the second decade. And in X-ray, it shows sunburst appearance and Codman's triangle. Treatment is wide excision with neoadjuvant chemotherapy and chemotherapy with radiotherapy. Although it is radio resistant, radiotherapy may or may not be given. The metastasis occurs in the lungs, same as our giant cell tumor. It has lung mets. So here also lung mets. So osteosarcoma shows a sunburst appearance and Codman's angle. It is formed in the metaphysis in 10 to 20 years. It is the primary osteosarcoma, and in 20 to 40 years it is associated with the Paget's disease. It is known as the secondary osteosarcoma. In osteosarcoma, the tumor is pulsatile, and because it occurs in the immature bone, epiphyseal plate is present, and therefore it cannot go to the epiphysis, and it is restricted to the metaphysis. And the treatment is wide excision, neoadjuvant chemotherapy, and radiotherapy. And then we come to our chondrosarcoma. Chondrosarcoma, it is also known as chondrosarcoma, is the malignant form of osteochondroma. Osteochondroma is also known as exostosis. Osteochondroma grows away from the junction of the bone and stops growing after skeletal maturity. A cartilage cap formation more than 2 centimeter indicates malignant transformation to chondrosarcoma. It is seen by MRI. More than 2 centimeter cartilage cap indicates malignant transformation. Multiple hereditary is by exostosis gene EXT1 and 2, and it is autosomal dominant, and it indicates promotes malignant transformation. And in intra-articular osteochondroma, it is known as the Trevor's disease. If there is malignant transformation of osteochondroma, it is known as the osteosarcoma. In osteosarcoma, there is endosteal scalloping, popcorn calcification, and it is also radio and chemo resistant, but it can cause paraneoplastic syndrome, hyperglycemia, and pelvis and proximal femur is mostly affected. Chondrosarcoma is associated with endosteal scalloping, and with endosteal scalloping in X-ray we see popcorn calcification in chondrosarcoma, which is a malignant form, and paraneoplastic syndrome shows hyperglycemia. It mostly affects pelvis and proximal femur, and it is radio and chemo resistant. Now coming to the most common tumor of the bone, this is most common at distal femur, and this is self-resolving. This is the fibrous cortical defect. the unicameral bone cyst and aneurysmal bone cyst. Unicameral bone cyst occurs in the humerus upper one third and it is symmetric, centric and serous on aspiration, while as aneurysmal bone cyst occurs in the knee and it is asymmetric and it shows soap bubble appearance, and it is eccentric and blood comes out in aspiration. So in X-ray we see a trapdoor or fallen leaf appearance. Here we see a soap bubble appearance. Here the treatment is aspiration with autologous bone graft or sclerotherapy and steroid. Here the management is extensive curettage with bone cement N2 and phenol, just like giant cell carcinoma, giant cell tumor, that is osteoclastoma, and embolization. So bone cyst can be of two types, aneurysmal and unicameral. And it occurs in the age of 10 to 20 years, and in the older people it is the more worse form that is happening, that is occurring in the knee, and it is asymmetric and eccentric, and blood comes out on aspiration, and it requires extensive curettage and embolization. And in unicameral bone cyst, the humerus is affected upper one third and it is symmetric and centric, and serous fluid comes out on aspiration. X-ray shows trapdoor or fallen leaf. And in treatment, there is aspiration being done and autologous bone graft, sclerotherapy or steroid. In enchondroma, hand, feet and metacarpals are affected. This also shows popcorn calcification. Popcorn calcification is also seen is chondrosarcoma. So in popcorn calcification, and the syndromes associated are Olier's and Maffucci syndrome.